Hello, I'm Nick Douglas, formerly of the Policy Innovation and Evaluation Research Unit at the London School of Hygiene and Tropical Medicine. Today I'm going to be talking about aligning health and social care in practice, observing multidisciplinary team meetings, and I'd like to acknowledge my co-authors, Mustafa Al-Haboubi, Tommaso Manacorda, Fanny Thana, Mary Alison Jerome, Gerald Wistow, Bob Erins and Nicholas Mays. So I'm going to be talking about bit about the context of the Integrated Care and Support Pioneer Programme and Evaluation, say something about the objectives, the observations, a little about the theoretical model and key concepts that inform the study, something about methods and analysis, present some headline emerging findings and some tentative conclusions. The Pioneer Programme was initiated by the Department of Health and 12 national partners with the ambition to make joined up and coordinated health and care the norm by 2018, with a focus on integration between health and adult social care. This meant that 25 geographically and socio-demographically varied areas in England were designated health and social care pioneers with the ambition to drive change at scale and pace. The Policy Innovation and Evaluation Research Unit was commissioned to conduct the early evaluation, which included the first 14 pioneers, and this was an exploratory study, including documentary analysis, development of logic models and 2 rounds of qualitative interviews. The second longer-term evaluation sought to assess the extent to which the pioneers were successful in providing person-centred, coordinated care and improving outcomes and quality of care in a cost-effective way, and to identify what works best in delivering integrated care in different contexts. And this was to be done by 3 work packages: process and limited impact evaluation, impact and economic evaluation of specific initiatives, and working with sites to test findings. One of the impact and economic evaluations was of community-based MDTs. There have been numerous studies of MDTs in various health contexts, but focus on integrated health and social care MDTs, and in particular the role of social care, is rare. The early evaluation found that community-based multidisciplinary teams were a ubiquitous and systemically important intervention within local pioneer programmes. This led to the design of a multi-method, quasi-experimental evaluation of community-based MDTs involving patients aged 55 and over, their informal carers and staff associated with the MDTs. So the objectives for the observations were to describe the composition of the MDTs, the skills mix, to assess key aspects of team functioning, to describe facilitators and barriers, to understand the nature of decision making, identify possible added value, and identify factors potentially salient but not yet known to us about what appeared to significantly affect the operation of the MDTs. We had a working definition of a community-based MDT, which included both primary care and social care professionals, as well as allied healthcare professionals and in some instances the community and voluntary sector, sought to bring these cross-professional groups together in a shared process of care coordination, and had a target population group that included people aged 55 plus with multiple long-term conditions, i.e. those that evidence suggests often demand complex care coordination and high levels of health and social care resource. The research was also underpinned by a working model of team functioning, which was based on early scoping work, and a key task for the observations was to enable the research team to develop a better understanding of aspects of the intervention process, specifically team functioning. We did 2 rounds of structured non-participant observations between June 2019 and February 2020 in 2 pioneer sites, which I'll call South and North. This included 11 community-based MDTs, and we observed 29 meetings across both sites. Meetings lasted approximately 45 minutes to 3 hours. Researchers observed in pairs and took written notes using structured data gathering tools. Additional information was collected from administrators following meetings, and we also conducted post hoc researcher debriefings, and considered reflections were written up soon after each meeting. And it's perhaps worth saying that we designed a kind of bespoke research process and information gathering tools to reflect the complexity of the situation that we were observing. In terms of analysis, we conducted 2 research team meetings using modified group analysis, and we included a critical friend who was a member of the research team who had not conducted any observations. We did thematic analysis of the transcripts of those meetings and also thematically coded researcher notes. We also collated information, quantitative information about MDT membership, but I'm not going to present that today. So membership varied. Administrators, GPs, social workers, and nurses tended to be represented in almost all of the MDTs. Occupational therapists and physiotherapists were present in North 1 and 3. Mental health workers were present in the South meetings, and the community and voluntary sector were represented in the South and North 3 meetings. And where present, GPs tended to outnumber other staff on average by about 3 to 1. We perceive certain membership gaps, so in terms of housing department, learning disability services and substance misuse services, especially in the South meetings. And one researcher observed, I felt that the social worker often acted as an intermediary for housing, and I wondered if the care of patients was really impacted by a representative from housing not being able to be there or not being there, and also whether that actually slowed down decision making. In terms of team functioning, leadership within the meetings tended to vary. Sometimes there was someone clearly in a chairing role, but not always, and sometimes dyads and triads seemed to be informally leading. Interactions were collegial and respectful. The hierarchies tended to be fairly flat with no strong professional status distinctions, but there was some tendency for GPs to be the final arbiters in the South meetings. There were high degrees of patient-centeredness, but reflexivity was not strongly evident. There was less verbal participation by community and voluntary sector representatives in the South meetings, although we're somewhat unclear about why that is at the moment and are looking into that further. And it appeared to be a forum to get support with difficult cases. So one researcher observed, GPs seem to be really struggling to know what to do with really complex cases, and I felt that some of them had considered what to do. From what I saw, they weren't working in isolation. They were able to bring and receive support, probably also emotional support for dealing with quite difficult, in some cases, patients with really complex mental health and social needs, as well as physical. In terms of decision making, it wasn't always clear to us why a case had been referred in for review, but we were able to identify a pattern in the process of deliberation about cases. This included case presentation, information seeking and sharing, narrative construction, solution seeking, consensus building, decision making and task allocation, although this was not always a strictly linear process. There was decision making quite often by dyads and triads, but there was variation in the composition of those depending on who was present and the nature of the case. GPs, social workers and nurses were frequently central to the dyads and triads, but other configurations were seen. It was generally consensus-based decision-making, and there was no evidence of strong conflict. And the most common decision reached appeared to be deferral, in other words, watch and wait. And we speculated that this was related to intractability and complexity of many of the cases that reached the community-based MDT. One researcher observed, there seemed to be a lot of deferring of cases to future meetings. There was only one discharge, which didn't feel particularly productive. In terms of facilitators and barriers, facilitators included capable and participative administrators, cordial and collaborative professional relations between members, and experienced staff who were knowledgeable about their organisations and services. Barriers included poor IT provision and poor interoperability of patient information datasets, and the quality of meeting spaces varied considerably. They were all NHS facilities. Some were modern purpose-built clinics, but others also were shabby ageing facilities, and there were instances where meeting spaces were not really fit for purpose. There were some issues around information governance and consenting patients to enable them to be discussed, although workarounds have been found. And there were significant gaps in membership when critical staff left and concerns about how and when they would be replaced. So one researcher observed, the presence of a senior social worker at the meeting seemed to be essential, if only because it needed someone from social services present who was able to access the local authorities' systems. There was some concern about how well the MDT would function in the period between the departure of the current post holder and his successor. So in terms of summing up, on the question of added value, it seemed to be an efficient way to share information about patients, especially in light of ongoing IT interoperability problems, and to give information updates, and we saw that happening sometimes in real time during the meeting. For hard to engage patients, they could discuss which professionals, organisations or services had the best rapport and likelihood of engagement. And there was also evident sharing of information and learning about how their organisations and local health and social economies worked and how to navigate them. So one researcher observed, Different organisations explaining to others how they operate was a definite added value, and occasionally the medical background that the GP was explaining, which helped other organisations understand why they need to provide certain support, that was a definite added value. So a few tentative thoughts and conclusions. There's a significant problem of comparison for us in terms of the profile of cases considered, the professional roles represented, options for referral and deferral, and the local context and surrounding health and social care economy. But we were able to get more clarity on the composition of teams. This varied, but key core triads appeared to emerge for decision making. In terms of team functioning, we observed this to be collaborative, cordial and respectful, with relatively flat hierarchies, though chairing could have been clearer in some cases. We were also able to identify a discernible process in how community-based MDTs reviewed cases. We observed consensus decision making, but this could have been clearer at times, and deferral, or watch and wait, was the most common decision. Barriers remained in terms of IT problems and problems with information governance, but they were also facilitators in terms of capable administrators and experienced and knowledgeable staff. As mentioned, there was apparent added value in the community-based MDTs. This was related to information sharing about patients and mutual education about local health and social care systems and how to navigate them. But more research is needed on whether this leads to better and more cost-effective outcomes for patients, and this is a continuing part of the study. So thank you very much for listening. If you have any questions or comments on this presentation, please add them as a comment below this video and we'll read and respond. More information is available at www.piru.ac.uk. Thank you.